Hi, this is a case report of subacute endocarditis in a previous healthy man with undiagnosed bicuspid aortic valve. So to begin with, congenital bicuspid aortic valve, it's a structural abnormality of the heart, and it's believed to affect about 1% of the population. The problem with diagnosing congenital bicuspid aortic valve is most patients are asymptomatic until they're about like 50 years old. So it's pretty hard to detect if you're really not looking for it. In patients with infective endocarditis, usually a source of infection is found in either the HPI or the physical. But in the setting of a structural abnormality like a bicuspid aortic valve, it can just arise from transient bacteremia encountered in everyday situations such as brushing your teeth really hard or something related to oral dental work or just a checkup at the dentist. Infective endocarditis can lead to a lot of life-threatening morbidities and complications, but with early suspicion and medical intervention, it's got a pretty good prognosis, and a lot of those life-threatening morbidities can be prevented. That's kind of the purpose of this case, is to illustrate the presentation of it in a younger patient and when to suspect it. So our patient was a 37-year-old male. He presented with several months of self-reported fevers, night sweats, fatigue, and unintentional weight loss of about 40 pounds beginning in September of 2020. Outpatient tests ruled out HIV, Hep C, Hep B, hypothyroidism. They even were thinking of eosinophilic esophagitis because of the food aversion. And finally, he got a outpatient echo to investigate the possibility of endocarditis. And on that echo, they found pretty sizable aortic valve vegetation causing pretty big, severe aortic regurg. And then he was immediately referred to Beaumont Royal Oak ED and then was admitted inpatient for a workup. People kept pressing on him this, but he explicitly denied any history of drug usage, any needle usage, recent tattoos, anything introducing kind of bacteria into the blood, and any recent dental work also. Past medical history, really only von Willebrand disease, migraines, nephrolithiasis. No real significant contributory past surgical. Family history was non-contributory. He denied drinking, any tobacco use, and any previous history of illicit drug use. On physical exam, his vitals were stable. His heart rate was a little high at 90, but he was satting well. He was slightly diaphoretic, slightly sweaty. Eyes, ears, ENT was non-contributory. Cardiovascular, so he had a faint 2 out of 6 diastolic murmur at his left upper sternal border, but otherwise no signs of JVD or pedal edema or anything like that. Respiratory is good. Jumping down to skin, he had the presence of about 2 to 3 millimeter non-tender lesions on the right side of his palmar side of his hand, right underneath his right thumb and index finger. Otherwise, his physical exam was non-contributory. So getting into the timeline, I put it up there. So he's admitted. Jumping to November 19th, CTA showed that he had a pretty bulky aortic valve vegetation, and he also had an aortic valve abscess, but it was at the aortomitral continuity. So I put an image right there. Oh, there's my mouse. And that's kind of highlighting the abscess, the vegetation that was found on his aortic valve. It's on the ventricular side of his heart. Two separate blood cultures were drawn. They both grew strep viridans. He started on ceftriaxone. The antibiotics helped relieve his symptoms quite a bit. And then he underwent a aortic valve replacement on the 27th, as well as absence drainage. And then he was anticoagulated because of his valve creating turbulent flow per protocol on warfarin. And he did pretty well. He was discharged home, and he just had one episode of effusion, pericardial effusion, and it was just drained. he's been doing okay since then, just based on his follow-up notes. He's recovering well. He's able to engage in like light yard work and stuff like that. It said so. He's doing okay. This is the picture, like I was saying, of the vegetation on the aortic valve. So quick teaching point I wanted to address, I guess, is using Duke's modified criteria to make the clinical diagnosis in this case. So it's a clinical diagnosis based on clinical symptoms. Obviously, if you have pathology, you can just confirm it without this. But to clinically diagnose it, infective endocarditis, you need either 2 major criteria, 1 major, 3 minor, or 5 minor criteria. And the major criteria in this particular case, so he had 2 blood cultures drawn from separate sites. Important point, before antibiotics were started. So blood cultures were drawn before antibiotics were started. That way no bacteria were killed, and both those grew strep viridans per the timeline earlier. And he also had evidence on echo of a vegetation and abscess and valvular groove. So he had all 3. Important point, you only need 1 of these to meet the major criteria. He also had 3 minor, so he had a pre-existing heart condition, his bicuspid. He had intermittent fevers he was measuring at home. He's afebrile right now, but he had at home. And then he had Janeway lesions, so those non-tender lesions on the palmar side of his hand. And that's shown here. They're thought to be caused by small septic emboli shooting off from the vegetation itself and just causing, lodging the microvascular, and then cause a little micro abscess, causing a raised lesion. And then right here is just a quick picture of vegetations on the aortic valve, what they might look like on echo. So complications of infective endocarditis, why it's so important to catch early. There's quite a few, some neuro. It's mainly related to emboli shooting off from the vegetation. So you could have an embolic stroke, brain abscess, intracerebral hemorrhage. They shoot off to the lungs, similar to a PE, presentation-wise. And then you can also obviously have heart failure just from like severe aortic regurg and other valve abnormalities. You can also get conduction block. So that's one thing I wanted to hit. He had a abscess in his aortomitral curtain. So he got, I think, pretty lucky in that his abscess extended right about here, and you have a lot of high real estate with all the conduction system going down into the heart, AV node and left bundle being there. And so he's lucky that his abscess wasn't compressing on stuff. And that's a frequent complication seen when abscesses are allowed to develop, is conduction abnormalities causing heart block and even lead to death. So moving on, screening tidbit, screening family members for bicuspid aortic valve. I thought this was interesting. So it has a inheritive property. So about 10% of first-degree relatives of patients with bicuspid aortic valve are thought to have the structural defect. So it's important because these guys also might get dental work or something like that, and maybe they need antibiotic prophylaxis after that dental work, just to make sure that they're not also getting like vegetations and stuff like that, and they might be more prone to like aortic stenosis and stuff down the line. So it's important that these guys are screened. So the American Heart Association recommends all first-degree relatives are screened. And then just to conclude real quick, so infective endocarditis is a highly treatable disease with a favorable prognosis if it's diagnosed early, meaning that you prevent all those potentially morbid complications from developing. So the purpose of this case was to just illustrate the importance of having a high index of suspicion for infective endocarditis in patients when you're ruling out a lot of other things and they still have unexplained food aversion, chronic fevers, night sweats, and other non-specific symptoms. I hope you consider aortic or infective endocarditis. Okay, thanks so much.